This is the AAST Communications Committee Quickshot interviews. I'm Dr. Daniel Grabeau, and I'll be interviewing Dr. Cheryl Zogg from Yale University. We'll be discussing her paper on the extent to which geography explains one of trauma's troubling trends, insurance-based differences in appropriate interfacility transfer. Dr. Zogg, thank you for joining me today. I hope you're doing well.
No complaints.
Great. First question is, what got you started with this project, and basically how'd you come up with the idea to research this topic?
Sure. So a couple of years ago for the American Surgical Association, myself and my co-authors had done some work trying to understand the extent to which this phenomena that's been described in the literature of uninsured patients presenting to lower level trauma centers and non-trauma centers with pretty severe injuries that we would expect to see treated in a higher level 1 or 2 trauma center. We're kind of having these insurance-based differences in triage patterns, such that in a somewhat counterintuitive way, we were seeing uninsured patients with major injuries actually, at least theoretically, getting better care, and followed that forward to look at outcomes. Now, one of the multiple theories put forward to explain this trend has been that there might be underlying geographic differences at play, particularly in rural hospitals where patients presenting to non-trauma centers might not have ready access to other options of care. And so the purpose of this study, kind of as a follow-up piece to that original work, was to really explore the geographic supposition, asking whether and to what extent geography was influencing these somewhat counterintuitive results that we were seeing.
Great, thank you. Well, with that, can you give us a brief synopsis of the results of your paper?
Sure. So kind of building what I had said before, the two major objectives of the study were to see if not just clustering of patients presenting to non-trauma centers made a difference, but also then moving that up to look at clustering of non-trauma centers within what are known as hospital referral regions. And these come straight from the Dartmouth Atlas. They're kind of thought to be networks of hospitals centered around access to higher level cardiac and neurosurgical care, as well as the distance and travel time by road from the non-trauma center to the nearest level 1 or 2 trauma center in an effort to really understand the extent to which geography might be at play. And what we saw was that for the first objective, additional clustering of non-trauma centers within referral regions did not affect the results. And these regionalized systems of care were not driving these outcomes observed. However, when we turned to spatial analyses to try and understand whether geography had an influence, we did see significant trends. And what was concerning, quite frankly, from the results was that while geography was having an influence, it was having an influence in directly the opposite manner to which kind of conventional wisdom suggests. And by that, I mean that we were seeing larger insurance-based differences among non-trauma centers located closer to larger trauma centers, particularly in metropolitan areas, and particularly among those treating kind of wealthier and less socioeconomically disadvantaged patients, really suggesting that there is something going on here at the non-trauma center level that can't be explained away by geography alone.
Gotcha, great. So if there's one takeaway that you would want us, the listeners and the people listening to your presentation, to take away from this study, what would we take away so that we can take that forward and make some changes in the way we take care of our trauma patients, especially at the system level?
Yeah, I think the biggest thing is recognizing that within these non-trauma centers, where a large proportion of patients, for better or for worse under triage guidelines, are choosing or opting and ending up receiving care, there's a need to recognize and strengthen the trauma care that's happening within these systems, and particularly to understand why these insurance-based disparities continue to persist despite the national efforts to improve trauma system strengthening.
Very good. Great. Any future plans or studies to go along with this?
This particular work, I think we have to think about where we want to take it, but continuing through the tail end of my dissertation and the last couple of years of medical school to do a lot of work with access to care and how we evaluate quality among older adult trauma patients. So hopefully we can pull some of those pieces together and help kind of get at the underlying issues that we're seeing in this work.
Great. All right. Well, that's all I have. Thank you so much for taking the time to speak with us today.
All right. Thank you.
Thanks.